Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Noha from Masan'a Polyclinic. Today we will speak about the common gynecological cancers and the method for screening if it is needed for each cancer. The objective, first, early diagnosis, key steps in improving cancer survival. Second, to identify women with risk factor for gynecological cancer and improve knowledge of red flag symptoms. Third, to recall the relative risk for gynecological cancer. Fourth, recognize the various methods for screening. Fifth, increase confidence in when and not to refer patient on suspected cancer referral. And lastly, to improve communication to support patient throughout the diagnosis. As you know, each cancer has a specific color, but for all gynecological cancer will be this color for ovarian cancer, different color for uterine endometrial cancer, other color, and so on. So for all gynecological cancer, we use the purple color. The most common cancer here, it will be this color, endometrial cancer. The most deadly cancer is ovarian cancer, which is appear as green ripen. So in common gynecological cancer, the sign and symptom and the color used for it are as follow. For ovarian cancer, if any woman has history of loss of appetite, feeling full quickly, gas, indigestion, bloating, nausea, frequent urination, pelvic pain or pressure, especially if this is for the first time, and the patient above 50, we must put in mind maybe ovarian cancer, but not necessary. But we'll take full history. If has any family history of ovarian cancer, then we'll do the screening. And we'll discuss this later in next slide. About the uterine cancer, there will be postmenopausal bleeding, irregular bleeding, intermenstrual bleeding, heavy menstrual bleeding, and also pelvic pain. And if you find that, it's mostly occur also in elderly people. For the vulval cancer, there will be constant itching or burning of the vulva, or change in the skin or color of the vulva. Vaginal cancer, there will be postmenopausal bleeding, pain bleeding during intercourse, bleeding pain and constipation and vaginal mass. Cervical cancer, there will be also intermenstrual bleeding, postmenopausal bleeding, pain or bleeding during intercourse means postcoital bleeding, and significant watery or foul smelling discharge. We'll discuss each cancer and the method of screening if needed. So again, this is just a diagram to show the cancer and the symptom that's present. It's the same information in the previous slide. From this diagram, you will know that the most common cancer is uterine cancer, but the most deadly cancer is ovarian cancer. Cervical cancer is reduced because of the screening program. Vaginal cancer and vulval cancer, little bit it's rare. Again, the most common cancer in women is a breast cancer, followed by lung, followed by colon, then uterus. So the uterus is the most common gynecological cancer, but the most common cancer in female is a breast cancer. Again, this is the number of cases and the death. From this paragraph, you will find that the most common deadly cancer is ovarian cancer because mostly it's diagnosed late in third stage. And the most common cancer is uterine. So we'll speak about uterine cancer. Most common gynecological cancer, as we said in the previous slide, and it's the fourth most common malignancy in women in UK. The peak incidence is 65 and 75. And they found that there's increased risk 2 to 4 times when menopause occur more than 52 versus menopause less than 49, and strongly associated with obesity. That's why there are many webinar, many workshops about the dangers of obesity, because they found that when manage obesity, there's reducing risk of uterine cancer. And endometrial cancer is often detected at early stage because it's frequently produce abnormal vaginal bleeding. So if endometrial cancer is discovered early, removing the uterus surgically often cures endometrial cancer. Again, there are something called endometrial hyperplasia, which are pre-malignant condition, either simple, complex, atypical, or with atypia. And the treatment is with progesterone. So I just put this slide in order to focus on the importance of doing ultrasound, especially in menopause. They have bleeding to find the endometrial thickness. So if there's endometrial hyperplasia, it's not necessarily to be cancer. It might be pre-malignant condition in which can be treated easily. The other cancer is endometrial cancer and sarcoma. This is all related to uterine cancer. So the most common cancer of uterine cancer is endometrial adenocarcinoma. So the risk factor, as we say, is occur more in elderly 45 and above, related to obesity and also estrogen excess. Estrogen excess also increase in obese because of the fatty deposition. Then they found that 37% of cases are caused by being too fat. That's mean if we reduce the obesity, there will be reduced the risk for endometrial cancer. What about genetic? Yes, uterine cancer may run in families where colon cancer is hereditary. Women in family with Lynch syndrome, also called hereditary non-polyposis colorectal cancer, have a higher risk for uterine cancer. What about diabetic and other, and also diabetic increase the risk for endometrial cancer? That's why in one talk article, they say if the woman is 40 years old and has intermenstrual bleeding and heavy menstrual bleeding with comorbidity like diabetic and hypertension, it's preferred to be sent for biopsy of the endometrium to rule out endometrial cancer. However, for any woman above 45 without comorbidity with heavy menstrual bleeding, we will do endometrial biopsy. But if there's comorbidity, 40 at 40 age, we will do the biopsy. What about other cancer? They found there's related between breast cancer, colon cancer, or ovarian cancer are increased risk of uterine cancer. Also, some women who are breast cancer and taking tamoxifen because tamoxifen will increase the endometrial thickness. Also, sometimes radiation therapy. Women who have had the previous radiation therapy for another cancer in the pelvic area can increase risk for uterine cancer. And diet and nutrition, it's very, very important, as I said, because eating foods high in animal fat may have increased risk for uterine cancer. So again, the obesity, nulliparity, early menarche, late menarche, unopposed estrogen, polycystic ovary, does mean whenever there is ovulation, there's estrogen, so there's risk for endometrial cancer. Tamoxifen, because as I say, increase endometrial thickness, and also some ovarian cancer, which lead to increased estrogen production, and also hereditary, which is Lynch syndrome. So what is Lynch syndrome? As I say, it is hereditary non-polyposis colorectal cancer. It is inherited changes in genes that affect DNA mismatch repair. It's happened as autosomal dominant. That means in every family, there will be one person with this Lynch syndrome. So having Lynch syndrome, need to do screening. In general, for uterine cancer, there is no accepted technique for endometrial cancer screening. of those with high risk factor, but a National Cancer Institute statement of endometrial screening in patient on tamoxifen for breast cancer, there is no rule for this. The type of cancer were no worse than endometrial cancer in the general population for stage, histology, and grade, and the prognosis was not altered by early detection through screening. That means for uterine cancer, no need to do screening even for high risk factor, except in one cases in Lynch syndrome, in which we say there is family history of ovarian or colon or breast cancer. Here we'll consider screening with endometrial biopsy every 1 to 2 years, starting at age 30 to 35, and if she complete her family for hysterectomy. So Lynch syndrome, in which is autosomal dominant that can run in families, they found it is a group of cancer, colon, uterine, and ovary. Can endometrial cancer be prevented? Yes, sometimes if you're taking birth spacing, which is COC or combined oral contraceptive, in this which will reduce the ovarian function and reduce estrogen. So this will reduce risk for cancer. Also using Mirena will also can reduce the risk for cancer, especially in women who are taking hormonal replacement therapy, which is estrogen. Sometimes they found if you added Mirena for these women, there is reducing the risk for endometrial cancer. Very, very important is to maintaining a healthy weight, as we say that they found the percentage of endometrial cancer is due to lifestyle and other risk factor will be reduced 37%. So if you have diabetic, good disease management, regularly monitoring blood glucose level can lower the risk. And as I say, if any woman with heavy menstrual bleeding, 45 and above, it is preferable to do endometrial biopsy. However, if the woman is 40 years old with comorbidity like diabetic and hypertension, it's preferred to do endometrial cancer in this age, even though she is younger than 45, but because of comorbidity, so it's preferred to do biopsy to rule out endometrial cancer because there is risk for increasing cancer in this group of patients. What are the signs and symptoms of endometrial cancer? As I say, there will be abnormal uterine bleeding, intermenstrual bleeding, postcoital bleeding, and sometimes women do cervical screening. There's abnormal pap test, which is the same cervical screening, difficult pain sometimes while urinating, and pain in the pelvic area. So again, for any abnormal vaginal bleeding, will advise the women to see a doctor. Any abnormal vaginal bleeding should be further evaluated by the doctor to rule out uterine cancer. What are the screening? We say the screening is not needed, only for example for Lynch. However, what are the screening method? If we need it, of course, take history. What history? We'll take the most important, the age of the patient, we'll take the body mass index, we'll take history of any family history of any cancer and any comorbidity, because these are like hypertension, diabetic, because these are the risk for endometrial cancer. So if there's one patient with family history like Lynch syndrome or uterine cancer, we'll prefer to do pelvic examination and we'll do TP scan, just to put in mind the endometrial cutoff in postmenopausal is 4 to 5 millim. But for premenopausal is 8 millim in proliferative phase and 16 millim in secretory phase. So if one premenopausal, for example, 40 years old, and we did a scan and found that the endometrium is 16 or 15, we will no need for this patient to do biopsy because this is normal in secretory phase. And more than 8 in proliferative face is considered abnormal. So if equal or more or less than 8 is normal in a proliferative phase. So we will do pelvic exam, transvaginal ultrasound, but we have to know the cutoff for postmenopausal women and premenopausal women. We might do endometrial biopsy or hysteroscopy. Again, of course, we will do full blood count, liver function test, renal function test, MRI, chest X-ray. This is according to the condition of the patient. But the most important is transvaginal ultrasound to know the endometrial thickness and endometrial biopsy after taking history of the patient. So you find here in this ultrasound, this is normal endometrium, and this is also normal endometrium. However, this is very big. So if we measure it, for example, and find 16 in postmenopausal, please send her to secondary hospital for pipal biopsy, hysteroscopy biopsy. If it is premenopause and was 14, considered as normal. So this is the pipal biopsy. It's very easy. It's available in secondary hospitals, or hysteroscopy to take biopsy from the endometrium. And of course, hysteroscopy is more accurate than pipal biopsy. The treatment, of course, will be by oncology, which may be medical or surgical, radiotherapy or chemotherapy. So what about ovarian cancer? Ovarian cancer is the second most common cancer in UK and fourth leading cause of cancer death in women in US after lung, breast, and colon. Ovarian cancer called the silent killer because asymptomatic in early stages in 75%, diagnosed with advanced stage disease. Peak age occur in 5th, 6th, and 7th decade. Majority are epithelial, means serous, epithelial tumor. The remainder are germ, sac cord, or mixed cell tumor. So there are risk factors that increase ovarian cancer, and there are some decreased risk. It's the same like the risk for endometrial cancer. So if there's increased risk of estrogen, there's increased risk for ovarian cancer, and at the same time for uterine cancer. So nullipara, infertility, early menarche, late menopause, HRT, all these increased risk for ovarian cancer. But what are factors that lead to decrease the risk are combined oral contraceptive pill, pregnancy, breastfeeding, hysterectomy, ovarectomy, sterilization. So it's related mostly to estrogen. If reduced estrogen, reduced risk for ovarian and uterine cancer. What about genetic factor? In general, if there's no family history, the risk for ovarian cancer, from every 100 women, there's 1 to 2 will have ovarian cancer. But if there's one first-degree relative, there is risk for 4 to 10%. If 2 first-degree relative, there is increase 3 to 23%. What about hereditary ovarian cancer syndrome? They found there's specific gene called BRCA1, BRCA2. In BRCA1, there is risk 50%. That's why there will be more screening for this group of patients. BRCA2, 27. For Lynch, there will be risk for ovarian cancer 12. As we say, for Lynch, it is colon, ovarian, and colon, ovarian, and uterine cancer. The symptoms of ovarian cancer, as we say, mostly are asymptomatic. That's why it is covered in anti-stage or third stage. Sometimes there will be lower abdominal pain, fragile mass, abdominal enlargement, vaginal bleeding, urinary or bowel symptom. So the sign and symptom of ovarian cancer, symptom unexplained fatigue as any other cancer, difficulty in eating, feeling full quickly, unexplained weight loss, weight gain. So please, for any woman telling you that she has weight loss, lost appetite, please, and she is in 40s or 50 years old and above, and also told you she has abdominal bloating, please just send her to the gynecologist just to do ultrasound or take further history if she has any family history of any cancer, because there might be possibility of early stage ovarian cancer. So the screening of ovarian cancer, the routine screening, as we say, there's no standardized or specific screening for ovarian cancer, but only in high risk, the screening will be by ultrasound and measuring serum tumor marker, which is CA-125. CA-125 to be done in post-menopausal, not pre-menopausal, and transvaginal ultrasound. But in hereditary, there's hereditary cancer, should undergo annual pelvic examination, CA-125, and DV ultrasound until childbearing is complete. As you remember from previous slide, for endometrial cancer, we say if there is Lynch syndrome in the family, we will do annual endometrial fitness every year, 2 years, till she complete her family, then we will do prophylactic hysterectomy and bilateral oophorectomy. A serum CA-125 does not need to be undertaken in premenopausal women when an ultrasound diagnosis of simple ovarian cyst has been made. Lactated dehydrogenase alpha-beta protein beta-SCG to be done if the woman less than 40 to rule out germ cell tumor. But if the patient is menopause, to do CA-125. Diagnostic tool is taking history, as we say, very important to take a history to evaluate whether this patient is low risk or high risk, and do pelvic examination, transvaginal ultrasound to see if there is any mass or any ovarian cyst, and of course the feature of this ovarian cyst, tumor marker, which is CA-125. It is for postmenopausal women. CT, MRI, this is according if it is a high risk and if there is high CA-125. So the workup for any ovarian mass must first categorize whether it is functional, benign, or malignant. They found that in premenopause, the risk for ovarian cancer is 1. In the premenopause, it's 1 in 3,000, but in most postmenopause, 1 in 1,000. That means it's more with age. The size of a tumor, we must know whether it's unilateral or bilateral, and we must know the CA-125 level, the ultrasound color Doppler, and the presence of septum. And it's very important to see if there's free fluid and ascites, because this is very important. That might be some source of cancer. CA-125, we say we will do it for postmenopausal because sometimes it's increased also in endometriosis, liver disease, menstruation, appendicitis, inflammatory bowel disease, and in pregnancy. In postmenopausal, with unilateral simple cyst less than 5 and normal CA-125, so we will do ultrasound for this woman and see if it is if there's any feature of cancer, we refer to the oncology. So, but if asymptomatic and simple, less than 5 centimeters, we'll do follow-up after 4 to 6 weeks. If it is result, that's all. If not result, it's better to do surgery and remove the cyst, because in postmenopausal, more than 1 centimeter ovarian cyst is significant. So it is recommended that ovarian cyst more than 1 centimeter in postmenopausal women should be initially assessed by measuring serum cancer 125. The cutoff is 30 international unit per mil, and to do transvaginal ultrasound. Appropriate tests should be carried out in any postmenopausal women who have developed symptom within the last 12 months. For example, if we have menopausal clinic, so for any menopausal woman, if she said that in the last 12 months she has irritable bowel syndrome, especially if she is above 50, and this is the first time, and she has significant family history, So it's better to do for her CA-125 and ultrasound to be able to see if there's any early ovarian cancer. In premenopause and asymptomatic, if unilateral mobile simple cyst less than 8, it's not with no family history, just observe 4 to 6 weeks. What we say in postmenopausal, if more than 1 centimeter, should do investigation and follow up 4 to 6 weeks. If not resolved, need surgery. But in premenopausal, just follow up and no further workup, especially if it is clear. There are specific criteria to differentiate whether it's a benign ovarian tumor or malignant. It's called International Ovarian Tumor Analysis, IOTA. So we will use P rule and M rule. So if it's unilateral cyst, presence of solid component when the largest solid component less than 7 million, presence of acoustic shadowing, smooth multilocular tumor with larger diameter less than 10 centimeter, and there's no blood flow. This is P rule, that's its P9. But if irregular, we put in mind this might be malignant. If there is ascites, please refer to secondary tertiary hospital oncology because this is very, very important. If there is poor papillary structure, also please put in mind that might be malignancy. If there is high blood flow, also, or the solid tumor not clear, more than 10 centimeter, also this is might be malignant tumor. So IOTA is to differentiate the P rules, benign, from M rules, malignant ovarian mass. So this is in general brief. According to Royal College, they make this simple chart about ovarian cancer, what is the causes, the symptom, the diagnosis, the treatment, and the follow-up. What about cervical cancer? Cervical cancer is the only cancer that screening is important to do in women, not like the ovarian or the endometrial, which there is no screening, only a specific group. Screening cancer for cervical cancer should be done for every woman from 25 years old. As you see here, this is the cervix. There are some changes in the cervix. If we pick it up early, can save the life of the woman. So cervical cancer, 80% occur in developing countries. Why? Because there is no screening, while in developed country is reduced because of the screening and because of the vaccination, in which I will explain in the following slides. The majority, as we say, are squamous cell carcinoma. Adenocarcinoma are less common. The risk factor, human papillomavirus, in which there is words type 16, 18, 31, 32. Smoking, oral contraceptive might increase risk of cervical cancer. Parity, they found more parity, there's increased risk of cervical cancer. Immunosuppression, and also if there is age of first full-term pregnancy, 77% higher in those under 17 years old. They found that the Carticel, which is the vaccination used to protect against human papillomavirus type 6, 11, 16, and 18, the incidence and mortality rate reduced due to this vaccination program. So how to prevent? The prevent is just using Carticel, used the national NHS cervical cancer vaccination, which we say it's a product against human papillomavirus type. The human papillomavirus type, there are around 100 serotypes. Most common 16 and 18 will lead to cervical cancer, but 6 and 12 is just skin warts. So using Carticel reduces the risk of cervical cancer. And also it's not only prevent cervical cancer, they found it's prevent anal, vulval, vaginal cancer, because all these cancer happen due to this human papillomavirus. The screening is by using either iron or liquid-based cytology. From 25 to 49 every 3 years. Women aged 50 to 64 invited every 5 years. And after that, it will be stopped. So we are using this in our polyclinic to use this iron spatula in which it's taken from the cervical 360-degree, and then scrap it on this slide and fixation by fixative spray. Cervical cancer symptom is the same: intermenstrual bleeding, heavy menstrual bleeding, pelvic pain, sometimes watery, offensive vaginal discharge. What about the vulval cancer? Vulval cancer account for 5% of cancer in female genital system. There may be sometimes discharge, bleeding, not related to the period. Sometimes there is sore or growth over the skin, burning sensation, pain, lost itching, thickened, raised red, white, dark patch on the skin. The cause is either it's related to human papillomavirus, as we say, Gardasil can prevent also vulval cancer, the vaccination we mentioned before, and sometimes the other cause of vulval cancer, something called vulval dystrophy or autoimmune process. So the risk factors are increasing age, vulval intraepithelial neoplasia, persistent infection with the human papillomavirus, lichen sclerosis, which we explained in another session about vulval pathology, and it's happening mostly in older women. It's mostly autoimmune and also smoking. The prevention, always practicing safer sex, using condom during sex can offer some protection against human papillomavirus. They advise about cervical screening and also about cervical can detect human papillomavirus and precancerous conditions such as vulval intraepithelial neoplasia. Advise also if they are smoking to stop smoking, and vaccination can reduce the chance of developing vulval cancer. Vulval cancer, same as vulval cancer, so it is the same as we say vaginal and vulval and cervical cancer, mostly caused by human papillomavirus, and the screening would be the same. What about the fallopian tube cancer? Fallopian tube cancer is the same like ovarian cancer. They are doing, this is like a diary in order for elderly women to pick up early sign and symptom of any cancer. For example, if there's any abnormal vaginal bleeding, put in mind maybe cervical cancer, maybe ovarian cancer, uterine cancer, vaginal cancer, but not vulval cancer. But if she feeling quickly difficulty eating, ovarian cancer. If she feels pelvic pain, pressure, might be uterine cancer or ovarian cancer. If she has frequent or need to urinate and or constipation, either ovarian cancer or vaginal cancer. Bloating, that's mean mostly ovarian cancer. And of course, this is according to her age, according to the history of any family history of cancer. And also if there's comorbidity, for example, she has abdominal or back pains. This is happening in any woman, but if she has family history of ovarian cancer, we must focus on more history and examination and screening to rule out if there's any early ovarian cancer. If there's itching, burning, tenderness in the vulva, especially in elderly women, postmenopausal, are not response to medication, and it's chronic vulval itching, we have to rule out vulval cancer. If there is change in the vulva color, such as rash, sore, or warts, also put in mind vulval cancer. So this is a slide about to whom we have to do the cancer. Breast screening must be done. And cervical cancer, there is screening. Breast and cervical cancer, there must be screening for these women. The breast cancer by regular self-examination and mammogram for women above 40, not 25. And for cervical cancer, we will do cervical screening, which is called pap smear. and also by giving human papillomavirus vaccine, which is called Cardisil, before 15 years old. About endometrial and uterine cancer, it is by doing ultrasound, especially if there is comorbidity, obesity, family history of cancer. The same is for ovarian cancer. If there's family history, or if the menopause has abdominal floating, we will do ultrasound and CA-125. And these are the references that are used for this uh, uh, PowerPoint. And if you have any question, feel free to ask anytime. Thank you very much for your listening.